Welcome to Conversations with Dr. Arasi Maran. In this episode, we're going to talk about medical treatments or medical options for the treatment of obesity. Specifically, what are the interventions we can do to break the dopamine pleasure cycle and the food addiction aspect of obesity. Joining with me here is Dr. Rana Pullatt. Dr. Rana Pullatt, what are the recent advances in the medical treatment for obesity?
That's a huge subject, and I hope we can do justice to it.
We'll try our best.
I think we can talk about the history of obesity medicine. You know, it's very, very difficult to actually develop medications for obesity, and we've been doing it, we've been trying to get good obesity medications in the market for a long time. The team of scientists have been trying. And if you look at it, it's littered with a bunch of failures. For example, the most famous ones are the sibutramine, which was used, which was then implicated in sudden cardiac death. Lorcaserin, which was found to increase cancer risk. So it was pulled from the market after FDA approval. And then you had a medication called rimonabant, which was not FDA approved, but approved in Europe and then pulled due to suicidal ideation. So that's the premise in which we start. So basically developing medications for obesity had been a huge endeavor. And obviously drug makers are very interested in it because these are blockbuster drugs.
Absolutely.
That potentially is, it's like a $260 billion direct obesity cost just in the treatment of obesity for the United States. So yes, you can see the market is huge. This is subtracting all the indirect costs. I'm not talking about loss of production, any of this. $260 billion is just the cost of obesity in the US. So you can see there's a worldwide epidemic. Almost 40% of the United States is obese, and if you look around the world, it's in the region of 25 to 30%, especially in India and China with the diabetes pandemic and the obesity pandemic. The epidemic going on. No wonder drug companies are so interested. So currently, there are a couple of hormonal forms of therapy which are a little bit more esoteric, which are geared towards childhood obesity in people who have POMC deficiency in children. There's a medication that can be used for that in people who have, or children that have a leptin deficiency. That's a very, very small niche segment.
Yes.
Now the wider group, which we'd be more interested in, and some of these are approved for use in childhood obesity too. So orlistat basically works by reducing GI absorption of fat. And so if you take fat, you're going to end up with diarrhea. This obviously is not very pleasant.
Yes, I can imagine all the disasters that could have happened.
People have GI upset, people have extreme amount of
bloating.
So, and the weight loss is extremely modest. It's not very sizable for you to lose a bunch of weight using orlistat alone. So it's not been a very popular medication. The other medications are medications that are actually used to control seizures. There's a combination phentermine topiramate, which is used quite a bit, and that has pretty good results in treating obesity.
As a cardiologist, I definitely have a problem with phentermine being used as a weight loss drug. It can definitely cause palpitations, mitral valve issues, and things like that. And again, risk versus benefit ratio, I just feel phentermine is just not good enough isolated, and should, I try to tell my patients not to be on phentermine for weight loss purposes.
Yeah, but it seems like the combination seems to be able to give weight loss with a good amount of risk-benefit ratio, and it's been used pretty successfully.
So the Qsymia, that's what you're talking about, right?
Yes.
The Topamax and phentermine combination, which was way better than the previous combination of fen-phen, right?
Yes.
That was like the worst of the worst, terrible cardiac issues. Then they decided we'll just pull the phentermine and then combine with something else and basically change the cocktail a little bit.
Yes, that reduced the risks associated with it dramatically. Then you have the bupropion naltrexone combination, which is otherwise known as Contrave, which works pretty well. Again, these are not medications that are originally supposed to be treated for as an obesity treatment, but people realize that this does cause
when they were on it, it was more of a
loss.
Yes.
Again, these are drugs that causes some amount of weight loss, but not anything dramatic. Then you have metformin, which is a really been used for a long time for treatment of insulin resistance. This can be an effective drug, especially in patients women who have PCOS. Metformin is a very effective treatment, and it does give some amount of weight loss. Insulin actually is an anabolic hormone, and it actually promotes weight gain in some people. Most exciting of the recent past has been the advent of these new group of drugs, which are the GLP-1 agonists, which basically really work on the GLP-1 receptor, which then has profound effects on weight loss as well as effects on satiety.
So before you go into this, can you talk about GLP-1 receptors? Where does it play? What is the basic science mechanism of it?
So basically, when you have bariatric surgery or when you have surgery for weight loss, especially like a surgery like gastric bypass, food bypasses the first portion of the small bowel, and which means that the food does not go from the stomach into the duodenum and into the jejunum. Instead, the food goes directly from a small gastric pouch into, say, mid-jejunum.
Okay.
And this really helps with weight loss, one, by the amount of caloric restriction that people are able to eat only small meals, and more importantly, the hormonal cascade that basically happens when that food bypasses the first portion of the intestine. You have GLP-1 release, which then makes you more insulin sensitive. So the insulin resistance goes away, and you become more insulin sensitive. And this was again discovered serendipitously, because as bariatric surgeons, we just worked on, let's plumb the intestines, let's cut the stomach. That was the history of bariatric surgery. But over course of time, surgeon scientists realized that people were getting discharged and they were already non-diabetic, people who came in with diabetes. So it was not just an effect of the weight loss that's causing it, because you don't have that dramatic a weight loss
in day
when you're
2 of
discharging
surgery,
the
yes.
patient. So when they were discharged, they were already on very, very little bit of diabetes medication. So
I still remember the story where you've told me your patient walked in with 100 units of insulin and walked out of the hospital not requiring insulin.
Yeah. So it's pretty dramatic what you can get. And when they studied that, they really realized the importance of hormonal basis and hormonal mechanisms of obesity. And so these drugs that currently are on the market with the GLP-1, which work on the GLP-1 receptor, work pretty similar to a surgical mechanism. So you have, medications like semaglutide, liraglutide. You might know it in commercial terms as Wegovy and Ozempic, and these are medications that work just on these receptors, thereby making your body a lot more insulin sensitive. This helps in weight loss, and in the region of 15 to 20% of total body weight loss.
Is that similar to gastric bypass or gastric sleeve surgery?
So it's more in the region of the gastric sleeve surgery, and we can touch upon all of these. I think in the future model of obesity treatment will be surgery with drugs, because certain people might be more sensitive to surgery, certain people may be more sensitive to drugs, or it could be like cancer.
A combination.
Yeah, cancer therapy where you have a combination.
So there's no free lunch, as we say, right? So what are the side effects of this GLP-1?
So in some patients, you can have a really bad nausea, emesis. Isolated cases of gastroparesis have been reported. However,
so gastroparesis, basically you're saying how the emptying of the stomach slows down, so food basically stays in the stomach, and patients are extremely uncomfortable about that.
Yes. So actually now, if you're having surgery, not just bariatric surgery, but any surgery, and you're on that medication, you really need to stop that medication before surgery, about 7 days before, to not have the effect. There are some new anesthesia guidelines towards that, especially when having elective surgery. Now, there's also
that's done for aspiration risk, right?
Yes.
The anesthesiologists don't want the patient to aspirate
Yeah.
gastric contents. Yeah.
Yes. There's also a medication which can be taken orally. Now, semaglutide and liraglutide are all injectable forms. Usually it's taken once a week. Then, just like you said, there's no free lunch. The dose initially started at a small dose, and then they keep increasing it to a dose where they think the patient can tolerate but still get significant weight loss. Now, there are reports of tachyphylaxis, of people getting more used to that medication and finding ways to eat around even those medicines. As you can see, that when you don't treat underlying cause or the underlying psychological issues, which we've not touched upon, this medication can just become a crutch, which really does not help
fix the problem.
Now, there's an oral form of it. It's called Riballus that you take every day. Some people tolerate that better. The next class of drugs that have come, and one that has just hit the market, which is very dramatic, is tirzepatide, which basically, tirzepatide works on GLP-1 as well as GIP. There are two receptors, and they really, that weight loss is as comparable to something like a gastric bypass, where you get 25 to 30% of body weight loss.
Is that Mounjaro you're talking about?
Yes.
Okay.
And it also reduces the amount of fat in your liver. And all of these medications have now been shown to have cardioprotective effects.
Absolutely.
Protects them against heart failure, cardiac arrhythmias, atrial fibrillation. So a lot of these medications have also cardiac benefits.
It's almost, obesity is crossing borders right now. Initially, it was just the primary care physician's problem. From there, it became an endocrinologist's problem. Then it became obesity medicine or bariatric surgeon's problem. Then it became a cardiologist's problem. I think as physicians, all of us as a community need to take ownership of this problem.
Yeah, and it's a very important thing you touched upon, because what obesity requires is an integrated way of
multidisciplinary
approach. And just getting mail order Mounjaro or Wegovy and injecting yourself is really not going to fix the issue. So obesity really requires a team. It requires psychologists, dietitians, medicine specialists, primary care physicians, your cardiologists, and surgeons. It's truly a multidisciplinary approach, and sometimes I see people just get it over from a mail order pharmacy or your local quack or your local pharmacy, which basically just makes it, and then they take it. They use it more, I'm just going to indulge in some food, and then I'm going to take a shot.
And it's also used as a quick fix, right?
Yeah.
I have a wedding in 2 months. I'm just going to take it for 2 months. And
yeah. Some of it causes a lot of dependence. I've seen patients who are running out of the drug almost like exhibit drug-seeking behavior. They are like, it's like almost become an opioid epidemic. And right now the drugs are all on short supply.
And the diabetic patients for whom this drug was, initially started for are struggling to get the medication.
Yeah, and so now we have certain, a lot of the insurance companies in the US do not cover treatment with this medication for weight loss. Or there may be exclusions in their policies,
including,
because these are obviously very expensive medications if you get it directly from the
Well, I'm sure that the pharma drug lords will definitely come up with a way around, because as you said, it's a multi-billion-dollar market.
Yes,
and
I welcome treatment for it, and tirzepatide is just one of the many drugs that are going to come that is going to dramatically alter the landscape of obesity treatment.
How about the risk of pancreatitis with this? I mean, pancreatitis is a really devastating complication.
Yes, it is. Any of this is theoretically possible, but it's a very, very small risk.
And how about thyroid cancers?
So in certain groups of patients, especially people with men or the multiple endocrine neoplasia who are more predisposed to thyroid malignancy, some of these drugs are contraindicated.
So I think it is very important to talk to your physician and kind of, develop your team itself to, before you start off on these drugs, and not go to some random office and say, hey, give me the shot.
Absolutely. If you have a psychological problem and you're indulging in emotional overeating, you will still find a way around eating all of these medications. Don't fix that, because for example, it is quite dramatic, right? We associate, it might be a memory, it might be a great memory. You might have, as a kid, been with your mother, making food, baking cookies, making cakes. And then when the kid grows up, that becomes a pleasurable thing, that gives them memories of their childhood. And then when suddenly they lose their parent, then food becomes their crutch. So there's a lot, it's a very, very complex science. And then some people suffer from binge eating disorder, BED, and that there are medications that actually treat that. So you can't just be like, I'm just going to treat it with a GLP-1 or just use it as a crutch because I've got to fit into a dress or a swimsuit. I think it requires a little bit more thought process than that.
Absolutely. When you talk about the memories and the thing, are we underestimating the psychological connection with food? And should, psychiatrists and psychologists have a bigger role in this obesity epidemic?
So in the US and my team, we obviously focus on a team-based approach, and we have psychologists very, very involved in the selection. It's almost like a selection criteria. We basically make sure that the patient is psychologically capable of handling surgery, that any of the underlying psychological issues have been addressed. Only then do they even come for a consultation.
So are you telling me I can't come to you today and have my bariatric surgery next week?
No, that's not the right approach. I think that that would be a really bad way of dealing with bariatric surgery. So that's why we focus on the team approach. We have a team of psychologists, we have a team of dietitians. We also then meet the patient meets with a surgeon, a nurse coordinator, and then we all discuss as a team. It's called a selection meeting, and then we say, oh, this person requires some more time with the psychologist. So this person requires some more time with dietary education. And then when all of that is satisfied, is then when the surgeon actually has a second discussion, get the patient approved for surgery, and then do the surgery. So it's not like, oh, I have got a weight problem, I'm just going to get surgery. And that would be the absolute worst way of doing it. And I think that's the same way with medications.
Absolutely.
You need a team approach. You need people to address it as a team. Otherwise, you're bound to fail.
So, in cardiology, we have like a heart team. When a patient is with multivessel coronary artery disease, the cardiac surgeon, the interventional cardiologist, the primary general cardiologist, we all sit together and discuss the patient. And same way in cancer patients, they have a tumor board meeting, right, where different specialties, the radiation oncologist, the medical oncologist, surgeon, surgical oncologist all meet together. I think obesity should be considered like that. And we should have a group of or team of people or providers addressing the problem.
Yes, and I think that's what it's going to evolve into. It's going to become truly multidisciplinary and multi-specialty, involving obesity medicine specialists as well as specialists across the field, because a lot of obesity is also caused by medications.
Absolutely.
So if people are on antidepressants, there are certain antidepressants that can actually promote weight gain. So you might be trying to fix their obesity. Somebody, the psychiatrist, might put them on an antidepressant, which might make them actually want to eat everything around. So you need a very, very team-based approach. So one of the first things I do when I see a patient with obesity is, talk to them about their obesity. Try to figure out where it happened, how it happened, the evolution of them. What did they
what was a childhood trauma which precipitated
psychological issues? For example, obesity can be a protective thing in certain kids who've had childhood sexual trauma.
Absolutely.
They eat food to basically protect themselves and use that emotionally. So I think it's a very complex disease. That's not an easy solution. Don't do a mail order pharmacy. It's just going to you're going to end up with issues down the line. So I think it needs to be a team-based approach, and over the course of the years, you'll see it evolve, like the tumor board and cancer treatment.
When we talk about this multidisciplinary approach, I think we definitely need to, bring in thyroid dysfunction, right? Hashimoto's thyroiditis or hypothyroidism is such a big factor in the cause of obesity in women. You think, I have heard of people historically just using Synthroid or levothyroxine as a weight loss medication and ending up with cardiac diseases because of thyroid toxicity. What are your thoughts on that?
Yeah, I think while looking at obesity, especially in women, you have to look at it in a very, very global fashion a global way of looking at it, because it's not just, women's bodies change so much over menarche, then you have pregnancy, lactation, then you have
perimenopausal,
your hormones start, your metabolism starts slowing down, and then you have menopause. So there's huge dramatic changes that happen. And thyroid disease is one of the factors that could happen. There's autoimmune diseases like Hashimoto's thyroiditis, sometimes pregnancy-induced hypothyroidism, or generally people with, corticosteroid excess. There are adrenal diseases that can cause obesity. So there are dramatic changes that can happen by just changing your thyroid hormone as well as cortisol, which is a stress hormone.
With autoimmune disease, for most autoimmune disease, prednisone is like the baseline standard of treatment. And prednisone just results in such massive weight gain also.
Absolutely. So any kind of stress steroid, like, steroids themselves are obesogenic. That's the term. These are weight-inducing medications, as well as not having a good circadian rhythm or a sleep cycle. If it's upset, then automatically your stress hormones are going to go up. When that happens, you have altered sleep cycle patterns. You are more prone to weight gain and not eating at the right time. So night shift workers, there have been studies that basically show that they are more prone to gaining weight.
Like truck drivers also.
Yeah. And a truck driving profession is especially very, very difficult because they travel long distances. And in order to keep up with concentration, because they're sitting there alone and they keep using food as a crutch to stay awake, as well as some sort of companionship. So I've seen a lot of truck drivers who end up being obese over time.
I mean, pandemic definitely played a role in obesity, right? Because at least in the past, pre-pandemic, we all went to work. Most people went to work on a day-to-day basis. There was a social engagement. And during pandemic, there was so much, there's been an increase of remote working.
Yes.
And therefore, our number of steps reduced, we became more sedentary, and kind of led to weight gain.
Yes, I think also not to discount the amount of stress that played a role in the pandemic. Stress-induced eating, as well as you rightly mentioned, all of those changes that reduce your physical activity. And more importantly, when you talked about, like, as you age, your metabolism slows down. So over the course of time, even what you eat, what you think is a normal-sized meal might end up in adding on the pounds. And as I said before, it doesn't take dramatically different amounts of food over the course of years. There's like this statistic that's floating around that a single potato chip, which is one extra 7 calories a day, will, from the age of 20 to 40, ends up in you becoming from normal weight to obese.
So, one of the statements I talk to my patients is, with every decade birthday, how we celebrate, this is my 20th birthday, my 30th birthday, my 40th birthday. I think we should also remind that our calorie need with every decade decreases. So you can never eat the way you are in your 20s and your 30s. You can never eat, in your 40s, you can never eat the way you were in your 30s. So
that's a broad general statement, and I would agree in a very broad sense, but again, it's very, very individual based, right? I mean, supposing you're an extremely active individual, that may not be
that's true.
necessarily
yes,
true.
Absolutely. But
I think you've hit upon a very important aspect, that women are especially prone to obesity because of the amount of changes, hormonal changes that happen over a course of time.
This concludes this episode of Conversation with Dr. Arasi Maran. In the next episode, we're going to be diving deep into the surgical interventions for the treatment of obesity. Please do join me. Thank you so much for listening. If you found us valuable, you can subscribe to the show on Apple Podcasts, Spotify, or any of your favorite podcast app. And also, please consider leaving us a rating or a review, as that helps others find the podcast too. I hope you have a great week ahead.